All right, welcome to the first ever Salivary Gland Jeopardy. Hopefully we'll have some more. Thanks for everybody for participating on this lovely New Year's Eve morning. We have a few celebrity head and neck guests piping in from around the country. So I will just briefly ask them to introduce themselves if they don't mind, starting with all of our head and neck baby pathological father, Peter Sadow, coming from Boston.
Hello, I'm Peter. Does that work?
That works. Also a former Pritzker medical student, so I got to throw that in there.
Oh yeah.
And then I suppose my pathological adopted sister, Darcy, also trained in head and neck and bone and soft tissue and cytology, if I'm not mistaken.
That is right. And Nicole was a fellow at MGH when I was there, so that's how we overlapped.
It was a beautiful overlap. And who else is visiting here as a celebrity guest? Andre?
I see Dr. Daniel Johnson.
Hi everyone, I'm Dan. Looking forward to it. I'm still getting into my office, so
Hi, I'm Andre. I'm not quite a celebrity.
Oh, there he is.
I'm here, yeah.
You're current fellow at MGH, is that correct?
Yeah, that's correct.
Andre, that's wonderful. Now be a doll and respond to my email.
And then who else is on there? Sorry, I'm trying to scroll through. Anybody else? All right.
I see Pari Jafari, who we wanted to come here as a resident and rejected us to stay at U of C.
Yes, you always try to poach our people and vice versa, but it's cool. All right, so thank you guys for coming. Hopefully this will be entertaining. Here's how things are going to work. So welcome. Let's see, can I get my thing moving? Welcome. Where's my cursor? Here we go. Welcome to Jeopardy. So, or as this PowerPoint calls it, Jeopardy. Just to give a shout out to our inspirer, our mentor, our muse for this day. So how it's going to work is going to be classic Jeopardy rules. After I read the answer, type the question in the chat. And so the first person to type the correct question in the chat is going to get the individual points for that category. If there are a couple of like additional immediately consecutive answers, like it was obvious that you got it, just not quick enough, that will go toward your PGY team points. Once, of course, if you're the first person to get that category, you go on and ask for the next category question or answer rather. And then for Final Jeopardy, there's no double Jeopardies, sorry. For Final Jeopardy, just send me an email with your wager and your question.
Are there daily doubles in there?
No.
Oh, thank God.
No daily doubles, just regular Jeopardy and one Final Jeopardy.
That is too much.
Can you hear my cheers?
Yeah, we do.
All right. Okay. So here are today's, we have to decide who's going to go first. So maybe, I think the first person that signed on second to me may have actually been Brooke. So I'm going to give Brooke the chance to go first in our game, if that's okay with everyone. So here are today's categories. Facts and figures. You should have learned this in med school. It's not a tumor. It is a tumor. What you gonna order? Basically like special stains, immunostains. And calling Dr. Siegel. Specifically, this is going to be about molecular testing. For those of you who aren't at UFC, he's the director of our molecular lab. All right, so to begin, if Brooke is out there and wants to select a category and a value.
Can we do, you should have learned this in med school for 200.
200. This gland is composed entirely of the pictured cells. Okay, Perry gets what is parotid. Woo!
So yeah, I guess remember the following Jeopardy conventions and the question. Hey, Dr. Cipriani, since I'm scorekeeping here, how are we? We're doing this by PGY class, correct?
So take down the name of the person who gets it, and then if somebody gets it like immediately after, the person who gets it first will go for their individual points, and like if somebody gets it right after, that will go towards their class. But just write down the names of the people who get it. So
Why is everyone anti-camera?
I don't know. They're very
It's,
shy.
The
So
departmental
if you,
tradition.
so let's use this as an example. So Cirrus, the question was this gland, right? So the gland is the question. Parotid is correct, but you did not phrase it in the form of a question. Parathyroid is just incorrect. And what is parotid? There we go. That's how we want to see these answers going. Everybody good?
So I'm tabulating individual and class scores.
Well, yes, but the only person to get it here is Perry,
I see.
right?
Does
'Cause
everyone
either
else
it was
get negative
incorrect or not
points?
phrased in the form of a question.
I'm not keeping track of negative points.
No. Just so right now, Perry gets the 200. All right, and Perry gets to choose the next.
Ooh, let's see. How about, let's be conservative. You should have learned this in med school for 100.
All right. These are the major salivary glands. 3 major salivary glands. All right. I see Mia, Tanner, hold on. Mia comes first at what is parotid, submandibular, and sublingual, with Tanner, Perry, Kyle, Christine, and Fiza shortly thereafter. So Mia gets the individual score, and we'll give group scores to the others. Excellent. But if you're like significantly, Mia is a fast typer. All right. So Mia, you get to choose next.
Ooh, I want to do molecular. So call Dr. Siegel for 300.
Dang. All right. Calling Dr. Siegel for 300. The pictured tumor most commonly harbors fusion of these 2 genes. These 2 genes. All right, we have a correct answer with Tanner, subsequently followed by Perry. What is MIB NFIB? What is MIB NFIB? Everyone types really, really quickly. Well done. So I'm going to ask Tanner to tell us not only, he's already given us the correct genes, but what is the name of this tumor?
Hang on a sec. I'm trying to think.
Just
Adenoid
nope.
cystic.
Adenoid cystic, excellent. So we have classic cribiform growth with bluish mucinous material filling the cribiform spaces, bilayered ducts formed of epithelial and myoepithelial cells. And in fact, this is adenoid cystic. The most common dual gene fusion is MIB NFIB, or secondarily, Perry said NFIB, MIB, same thing. All right, excellent. Tanner gets to choose our next category.
Just for you guys at home, I recommend typing in what is before you need to go ahead and type. It'll save you time and give you a chance.
Nice.
I'm going to go with 200 facts and figures.
All right, 200 facts and figures. This is the most common salivary carcinoma. Woo! All right, a few answers piping in. What is mucoepidermoid? Correct. Perry, rocking it. Can I give a cheer? Ah! That wasn't what I wanted to show you. Sorry, guys. Now you have the question for the next one. I don't know what I just clicked. All right, so Perry gets the points for that one. And am I sharing my screen or no?
We've got the presenter view.
Oh dear. Okay.
You can swap displays.
Yeah. Let me do. that guy. Is that better?
Yeah.
Okay. Excellent.
I'll try to be honorable and not ask for another fact and figures, just in case we see that one again. Let me see. How about, you should have learned this in med school for 300.
You should have learned this in med school for 300. The pictured cells produce this substance. We have an answer with, I'm going to go with zymogen granules. So trypsin, chymotrypsin. So if you think about the types of digestive enzymes, there are a number of them. What I was looking for specifically was just the more, I guess what I was looking for generally was just the pre-digestive enzymes or the zymogen granules. So we're going to give this one to Tanner. And go back to the board.
Let's do, you should have learned this in med school for 400.
400. The product, you can see there's a theme of the pictured cells, can be highlighted with this special stain. All right, we have, what is PAS is nearly there, but Tanner gets it again with PASD. Excellent. Can you tell us about PASD?
So a PAS would highlight the zymogen granules and glycogen, but PASD would not highlight glycogen as it would be digested out and only highlight the zymogen granules.
Excellent. All right. Back home.
Let's finish the you should have learned this in med school category.
Yes. And I see somebody saying PAS is technically correct. Correct, but it's less of a specific answer. All right, 500. These two intracellular substances are resistant to diastase. We already heard about one, but I need you to type in both. What is mucin and zymogen granules? Yes, that would be correct. So again, zymogen granules generally referring to any pre-digestive enzyme, and mucin indeed also being resistant to diastase. So well done. Well done.
Hey, sorry, who got that one?
I believe that was Tanner. I'm going with the, we can give, if you're doing if you want to give a secondary answer to the people who appropriately either said what is trypsin in some of these, you can, however, you know, I'm going to give mucin and zymogen granules to the number one.
So far, I've just been doing a winner take all score recording. So
got it. Okay, that's fine. We can figure it out later because we'll have recordings of the chats. All right.
Oh, yeah.
So we're going back to Tanner.
Let's go facts and figures for 100.
Did it get it? No. This is the most common salivary tumor. Oh, we have a number coming in. Excellent, excellent. We have, what is PA? Looks like that's coming from Kyle. Excellent.
Right. Kyle putting the PGY3s on the board.
PA meaning?
Pleomorphic adenoma.
Fantastic. A lot of people got it. So we're going back home. And Kyle gets to choose this one.
Calling Dr. Siegel for 100.
Excellent. We have, when the pictured carcinoma transformed from a benign tumor, it likely retained abnormality in this gene. And we have a number of correct answers, including PLAG. So I believe this goes to Heather Chen. So Heather, what does PLAG stand for?
I'm gonna guess pleomorphic adenoma gene, but I might not be.
Yes,
Okay.
it is what it is. Excellent. So you go back to our board. So how did you know this was coming from a pleomorphic adenoma, and what is the diagnosis on this slide?
I think this is a pleomorphic adenoma X carcinoma or X. Oh shoot, was it X pleomorphic adenoma carcinoma? Oh shoot, I'm trying to think.
Yeah, just flip the words. Carcinoma X pleomorphic adenoma.
Yeah,
and how did
carcinoma
you
X
know that it
pleomorphic
was
adenoma.
that?
Yes. And I think it's just some of the stroma in the background reminds me of pleomorphic adenoma. And with a pleomorphic adenoma, you have a variety of different structures. But this also looks not well circumscribed and more invasive because here as well. That's
Excellent. So yeah, sometimes carcinoma X, the only residual portion you have of the residual PA is a kind of hyalinized, nearly dead nodule with only a few tubulo kind of ductular structures in it. And then it sort of tongues out into these nests of invasive carcinoma. Exactly. So classic for carcinoma X. Most of these have abnormalities in PLAG gene. Anybody know what the second most common gene problem in pleomorphic adenoma is? Secondary to PLAG?
Yeah,
Yep,
HMGA2.
HMGA2. Exactly.
I'm going to give a bonus for that.
Yeah, bonus. Exactly. Give a tack on a couple points. Yeah. So those are the common drivers of PA. Well done. All right, we're going to go home. So Heather gets to choose.
I will do, why don't we do it's not a tumor for 200.
Not a tumor for 200. These are the two cell types characteristic of the pictured tumor.
You just clicked on the tumor one instead of the not a tumor one, which is what she asked for.
Oh, I'm sorry.
This one is a tumor.
Oops, well, she gets this one. She can choose the next one next time. Okay, sorry. We'll do that one. We'll do it's only 8:20. I'm not awake.
Apparently it's acoustic neuroma.
So the correct answer is Tanner. What is oncocytic lymphocytic? So what tumor is it, Tanner?
This is a Warthin tumor.
This is a Warthin tumor. How did you know that?
Because they normally kind of have this cystic appearance, grossly.
Yes, filled with this gooey, grungy, gross material. Exactly. So characteristic gooey, grungy, gross, cystic cut surface of a Warthin.
And this is not like actually a beautiful color for it. What color might you anticipate that it actually would be in terms of furniture?
Oh, yeah.
Furniture.
Poo brown. Ooh, mahogany.
Mahogany, that's right.
So did she really ask for it's not a tumor?
Yes.
I did, yeah.
Okay, sorry. I'm gonna recuperate that. We're gonna go back to that. Okay. This many lymphoid foci in a 4 millimeter squared field is suggestive of Sjogren syndrome. This many lymphoid foci.
Oh.
You're putting controversial topics.
I know, right? Okay, well, I'm stopping the answers. We have what is 50 and what is 2 and what is 1 or more focus of 50. Yeah, sorry, we're gonna stop here. So the correct answer is any focus, including 1, such as listed in this chart, is suggestive of Sjogren syndrome. So a lymphoid focus is 50 lymphocytes. You are correct who said 50, but you don't need 50 foci. You need 1 focus full of 50 lymphocytes. So nobody gets this because we had what is 50 and what is 2 foci. And then after the timer went off, we had what is 1 focus of 50. So I guess Ryan gets a little bit of a point, but it was quite delayed. So I'm actually going to give him only partial credit, and we're going to go back to the person who won last round but didn't get to guess because I screwed up. So I think, who won the last round? after
Yeah.
Heather. Was that Tanner again? Yes, for the Warthin tumor. Okay.
What was that one worth?
Does it make sense what I'm doing?
Yes.
Because the correct answer came too delayed. Okay, so we're going back to Tanner.
Let's do calling Dr. Siegel for 200.
Mm-hmm. Rearrangement involving this gene is present in most cases of the pictured tumor.
Timed out.
See, there is the timer, I don't know, did you see the timer go off on the bottom? It's red.
Yeah,
and then it goes,
we see it.
Okay, so yes, the correct answer in fact is Melissa for CRTC mammal, but also these came after the timer, so we'll give partial credit, and we will give, actually, who came first? Kyle came first with mammal too. So I was only asking for a single gene in this case. So we'll give it to Kyle, but CRTC mammal are also considered correct. So what tumor is it, Kyle?
Mucoep.
Mucoep, exactly. So sometimes mucoep can be cystic, sometimes it can be more solid. But you see here these kind of intermediate to squamoid cells, and then many of these very pale mucinous cells. So we'll give Kyle the next guess.
It's not a tumor for 500.
It's not a tumor for 500. The pictured lesion is named after this animal. Oh, I gave you the answer, but the correct what is frog came before I clicked. So yes, what is frog? So the answer here is ranula, which is a type of mucocele, basically a mucocele that sort of bubbles up into the floor of mouth and mimics the gullet or the throat of a frog. So frog coming from rana in Latin. So
That's
we're going to
kind of
give this one
amazing.
to
I was looking at the picture. I'm like, what animal is a mucocele?
Oh, it's a ranula.
It's
There,
the Rana
see how
pipiens.
that is the burp, burp.
Yep.
Okay. All right, Perry. Oh, I won't click too much. Apparently I'm clicking too much.
Oh, 500 one.
How about it's not a tumor for 100?
It's not a tumor?
It is not a tumor.
I'm going to have to ask this every time now. Okay. In evaluation for Sjogren's syndrome, at least this many lymphocytes and plasma cells must be present in a lymphoid focus. Oh, I think we see, this is what happens when we skip. We already get the answers, but great. Perry gets it again. What is 50 lymphocytes and plasma cells must be present in a lymphoid focus? All right, back home.
How about another, it's not a tumor, this time for 300.
It's not a tumor for 300.
Right.
This is the name of the pictured lesion. Okay, so stop your answers because we have a winner. So we have a near winner with square met. I think you meant squamous metaplasia, but what I'm looking for is what is cyalometaplasia, going to Kyle. So explain to us, Kyle, what cyalometaplasia is.
It's where the salivary epithelial cells, there's squamous metaplasia of the salivary epithelial cells. As a
Exactly.
result
And in
of
what clinical context do you normally see that?
usually trauma.
Trauma, exactly. Radiation, any sort of injury or ischemia. Well done. All right.
That was a specific type of cyalometaplasia. You should put the picture back and ask him what's the right side of the slide.
All right. So what is the specific type of cyalometaplasia?
Because this is a fake out for cancer, so that's why people should see it.
Oops. Did I just click on the
Ranula.
Was it? What number was that? 300?
I don't know.
It
Was
was,
the one
Yeah,
on
I
your
think
page
it was
300?
300, yeah.
Okay, we're going back to that. So.
Yeah.
I will accept sialometaplasia, but technically, yes, the correct is necrotizing sialometaplasia, meaning a specific localized ulcer, often happening on the palate, that causes this sort of necrotic appearing space in the mucosa, but really is is extensive squamous metaplasia of salivary units
And
that can
it's
mimic
just
cancer.
that it's very recognizable by seeing that centrally necrotic stuff. And a biopsy of the tongue, for instance, or of the buccal mucosa can very easily be mistaken for squamous cell carcinoma if you're not anticipating the diagnosis. So that's the other thing, is just, I just wanted to point out for the residents, seeing that necrotic material present in the center should not make you freak out that this is a horrible malignancy. This is sort of a classic finding of necrotizing sialometaplasia. And the other thing that you can have that's very helpful is at low power, it retains the structure of the salivary gland. So you'll actually see the lobules of the salivary gland present there, and typically you have a lot of inflammation around it. So don't get faked out.
Excellent teaching point. Thank you.
I
can always rely on you to remember the things that I forget. All right, next vote.
What you gonna order for 300?
What you gonna order? What you gonna order when they come for you? This immunostain may show nuclear expression in the picture tumor, reflecting the underlying mutation. We have a correct answer with Tanner. What is beta-catenin? So Tanner, what is this tumor and why beta-catenin?
A basal cell adenoma.
Mm-hmm. How do you know that?
It's got peripheral palisading. It's got eosinophilic basement membrane material globules.
Mm-hmm.
It's relatively blue at low power.
Mm-hmm. And so your other differential diagnosis, I didn't give you the periphery of this lesion, but what would be your malignant kind of counterpart of this?
Basal cell adenocarcinoma.
Right, basal cell adenocarcinoma, which, generally both have similar morphologies of peripheral palisading, of eosinophilic basement membrane material, and the presence of either infiltration or not in a basal cell adenocarcinoma versus a basal cell adenoma. Now, this is not basal cell carcinoma like we see in the skin. What tumor, on the other hand, is actually very closely related to these that you might see in the skin? Anybody? Yes, Ben, cylindroma. So cylindroma, or these dermal kind of analog tumors, these turban tumors, is very similar histologically to basal cell adenoma, with sort of jigsaw puzzle pieces, and that's the CYLD gene. But in the salivary gland, you can have CYLD gene involvement, but more frequently in these, you also, or conversely, instead have beta-catenin nuclear positivity reflecting underlying beta-catenin mutation. Great. Comments, questions? All right, next.
Facts and figures 300.
Facts and figures 300. This salivary gland has the highest rate of tumors. Yes, we have Perry with what is parotid. So most salivary gland tumors are going to occur in the parotid. However, all right, back to facts and figures. I mean, back to the board. Choose facts and figures or choose something else, Perry.
Let me see. Sorry, I was muted. Why don't we go for facts and figures for 400?
Okay, see, I like continuity, because then we can learn something in consequence. This salivary gland has the highest rate of malignant tumors. Okay, Yes, Tanner gets what is sublingual, Kyle and Perry follow. So interestingly, and I don't know if anybody out there knows why, but if you guys can comment, but highest in terms of looking at the individual major glands, right? So parotid, submandibular, sublingual, well, somehow I have it written here as actually submandibular, but I will take, does anybody want to know if it's does anybody know if it's really submandibular or sublingual? Because I think the sources can be different between sublingual and submandibular.
Heard sublingual quoted most.
Yeah, I may just have the wrong answer here. So we're going to give it to sublingual. Thank you. I think I just typed in the wrong answer. Okay, go for it, Tanner.
Facts and figures 500.
Of all cancers in the US, salivary carcinoma represents this percentage. Of all cancers in the US, salivary carcinoma represents this percentage. We have what is 8%, what is 6% for head and neck, what is 5%, what is 6%. So this was a little bit of a trick question. Of all cancers in the US, salivary is less than 1%, but 6% of head and neck cancers. So I think this one's gonna go to Perry for a correct sub answer. Price is Right rules, 2%, which would still be too high. So less than 1% of all cancers in the US are salivary, but approximately 6% of head and neck. So we're gonna give this one to Perry.
We're still doing a course.
What?
We're still doing a course, even though it's less than 1%.
Yes. Well, yeah, because it's still, oh, you're still doing a course. Yeah, we're still doing a course if they ever accept us, which they're not going to.
Correct.
They don't like us. It's cool. All right, next.
Why don't we do It's Not a Tumor for 400?
It's not a tumor for 400. These are the most common symptoms of the pictured disease. These are the most common symptoms of the pictured disease. Okay, so excellent. Reading the question. What is sialolithiasis? What is pain with eating? What is bad breath? What is pain with eating? What is pain and paralysis? Okay, so in fact, this is sialolithiasis, but the question referred to the symptoms. So we're gonna go with pain and swelling, especially at mealtime. So we're gonna go with Perry. How did you know these were sialoliths?
They have that sort of laminated appearance. They look like stones of some sort that have been cut in cross section, I guess. Sort of basophilic in some areas, more eosinophilic in others. They look stony, I suppose.
Yeah. So they're a right, an acellular material, kind of circumferentially lamellated within a duct, right, which we see the ductal epithelium here. And so, yeah, so exactly. So this is an intraductal stone or sialolith, and pain, swelling, especially with eating, right? Because why during eating? Because you're producing all your saliva to lubricate and it's trying to get out and it can't. Okay. Well done. Go for it next.
Let me see. How about it is a tumor for 100?
It is a tumor for 100. This is the characteristic stroma of the pictured tumor. All right, so we have, what is chondromyxoid, first coming from Kyle Kissick? Excellent. So what is the pictured tumor? How did you know it?
Pleomorphic adenoma. It's got like this whitish tan appearance on the cut surface. And it looks like there's a little bit, like you can kind of hallucinate that there's a little bit of heterogeneity as well. Well circumscribed.
Great. So gross examination of salivary glands, especially pleomorphic adenomas, basically can look almost like cartilage, right? And so you have a very well circumscribed border. You have this very glassy white cut surface, which is, yes, Kyle 100, correct. So yes, excellent. Pleomorphic adenoma and chondroid or chondromyxoid stroma. And I think I have, yes, here's a picture of that chondroid stroma that looks very much like cartilage. Here's your normal gland at the top, and here's your characteristic bilayered ducts of a pleomorphic adenoma. All right, you get the next guess.
Calling Dr. Siegel for 400.
Calling Dr. Siegel for 400. We like our molecular. The pictured tumor shares the same genetic driver as one of these tumors. Pictured tumor shares the same genetic driver as one of these tumors. The pictured tumor, I'm going to keep going, shares this. Okay, Tim gets it with infantile fibrosarcoma. So this was a double, triple backwards question. So everyone who typed in was correct, but the answer to the question comes from Tim. So Tanner says secretory carcinoma, which is correct. That is the type of tumor here. It's formed of small cysts, sometimes with papillary structures. The cysts contain this very pale pink secretory material, sometimes a little bit darker pink, but the cells in the background are quite monotonous with these sort of oval nuclei, characteristic microcystic pattern, as well as sometimes intracytoplasmic secretory vacuoles. The rearrangement is ETV6 NTRK3, but the shared tumors that share this driver are either some other type of non-salivary gland secretory carcinoma, like that of the breast was the prime example, infantile fibrosarcoma, and congenital mesoblastic nephroma cellular type also have the ETV6 NTRK3 rearrangement. Anybody else have any comments on this tumor? I believe this type of tumor, I've never seen it, but maybe Peter or Darcy have in the thyroid gland, secretory carcinoma of the thyroid gland. Maybe Dan's seen it, I'm not sure.
Yeah, I've seen one or two cases. They look just the same.
Yeah.
We have a publication from May on NTRK related thyroid cancers.
Right.
And they
But
actually
they're not all secretory salivary type in morphology, right?
no, they're not, but they actually oftentimes they often look follicular patterned. So the sort of the picture you have on the left, they look very similar to that, but they don't have that sort of microcystic secretory look. That's sort of the classic picture of the salivary tumor in the middle.
Cool, thank you. All right, so we're gonna go with Tim on this one.
Those points go right in the trash.
Hello?
Yeah. Oh, sorry, I got to pick. Sorry, I was.
You got to pick, you won.
Yeah, right. We'll do, let's get the 100 out of the way. What are you going to order 100?
All right, what are you gonna order for 100? Results of these 2 immunostains may serve to guide treatment of this tumor. These 2 immunostains. All right, Tanner gets it with AR and HER2. So what's the tumor? How did you know it? And what's the importance of these stains? Tanner?
Sorry, I was muted. I think this is a salivary duct carcinoma, and it sort of resembles like high-grade DCAS in the breast. I think that there's some hormonal analogs they can use to treat these, or the anti-Herceptins as well.
Exactly. So when you have this sort of, this is generally an invasive carcinoma, but when you have this almost large nested DCIS-like look with cribiforming, or sometimes the oral people call this Roman bridging, with central necrosis and a very apocrine eosinophilic morphology that's very characteristic, burn it in your brain for salivary duct. These are often strongly positive for androgen receptor in the nucleus, so they can use HER2. I think I have a picture of it on the next slide. Oh my God, what am I doing? Okay.
These PowerPoints.
See,
can
I
get
just
kinda buggy.
gave you another question answer. My clickers aren't doing what I want them to. What I wanted to say was, you're not seeing anything now, are you?
No.
No.
Okay, good. I lost it. I wanted to show you a picture of AR and her too. Here it is. So, Zoom, share, desktop 2. Is this gonna work? All right, do you see that?
Yeah.
Okay. All right. So yeah, so strong nuclear expression of androgen receptor, they could treat these people with androgen antagonists, and HER2, they could certainly treat them with Herceptin. And so the strong like 3+ salivary duct carcinomas generally do have HER2 amplification by FISH. Sometimes the 1 or 2+ don't have the amplification, but generally this will be helpful for potentially diagnosis and certainly for treatment. All right, so the winner of this, going back to Tanner.
Calling Dr. Siegel for 500.
Okay. The pictured tumor shares the same genetic driver as one of these tumors. So same double back question. The pictured tumor shares the same genetic driver as one of these tumors. So what's the tumor, what's the driver, and what other tumor has that driver? The pictured tumor shares the same genetic driver as one of these tumors. Okay, so the genetic driver, we're going to stop because no one's actually getting it, is Melissa with EWSR ATF1. However, Ewing sarcoma is not a shared tumor. Anyone of the adult group want to answer this one?
Clear cell odontogenic carcinoma.
All right, yeah, we have clear cell odontogenic. We have Adam Fish with clear cell sarcoma, exactly. So let me go to the next slide. If it lets me. Yes, so this is in fact hyalinizing clear cell carcinoma of salivary gland origin. It does have the EWSR ATF1 fusion, and the clear cell carcinomas of the odontogenic origin within the bone have the exact same EWSR ATF rearrangement. Clear cell sarcoma, formerly known as malignant melanoma of soft parts, right, on the digits and the extremities, has the same rearrangement, and angiomatoid fibrous histiocytoma. So hopefully the question wasn't too confusing, but you know, when you think about tumors that have the same genetic rearrangement, your differential diagnosis is extremely narrowed. And so basically you're dealing in this case with, let me put it this way, EWSR is promiscuous, right? And so Ewing sarcoma isn't the only tumor that has EWSR gene rearrangement. Many tumors have EWSR gene rearrangement, but often the partner is the one that is going to be dictatorial of the narrowed down differential diagnosis. So in fact, this is, we're gonna give it at least partially to Melissa, because she got nearest to the answer with EWSR ATF1 hyalinizing clear cell, but it wasn't exactly answering the question. So Melissa, go for it.
Same problem I ran into. Hey, Melissa. She might have gotten pulled away briefly.
Okay, do you want to vote for her?
Yeah, sure. What are you going to order 200?
200. Pictured are two palate tumors. This immunostain best differentiates between the two. Okay, done. Tanner, what is P40? And sorry, Perry, what is P63 is not the answer. Tanner, tell us what the two tumors are and why P40 is helpful.
So if I'm not mistaken, one of these is the polymorphous cribiform, and then I can't remember the name of the other one. It's not a cynic cell. I can't remember the name of the other one.
We saw it earlier today. Cribiform growth. Anybody want to help them out?
Adenoid cystic.
Right. So the one on the left is probably more likely to be an adenoid cystic. The one on the right is potentially a polymorphous / cribiform adenocarcinoma. And why P40?
So my understanding was that P40 should be positive in the adenoid cystics, but diffusely negative in the polymorphous cribiform.
Right. So when you're dealing with small biopsies of things that have tubular, tubulocystic, cribiform morphology, one of your best differentiating factors is, do they have a single cell type or two cell types, meaning epithelial, myoepithelial? And so both adenoid cystic, as seen on the left, and pleomorphic adenoma both have myoepithelial cell component. So you should see P40 positivity actually here in like this abluminal component, but polymorphous should not have that myoepithelial component and should be completely negative for P40. P63 unfortunately has a little bit more overlap, so you might see some P63 positivity in polymorphous, but P40 should be dead negative. And S100 is actually not quite as specific for the myoepithelial cells of salivary gland. At least I've seen it be positive in some of the epithelial components. So S100 should be diffusely strongly positive in polymorphous adenocarcinoma, but you can also see some S100 patchy positivity in adenoid cystic, and you could also see diffuse and strong S100 positivity in myoepithelial rich, especially like plasmacytoid myoepithelial rich regions of pleomorphic adenomas. So I would argue that S100 is not as specific. Do you guys have comments on that?
We use S100.
Okay.
I mean, it usually is very diffusely positive in polymorphous, but yours is obviously P40 is the best single marker, but we always do a cocktail because we don't rely on any of our markers individually to work in any given, in any given case.
Right.
And then part of it ends up being based on the location of where you are and what your suspicion is for any of the entities involved.
Right. Yeah, no, I definitely wouldn't do it without the S100, but right, I found that sometimes there is some significant staining in the cellular.
But there definitely is. I don't think it doesn't distinguish them. That's why I typically will do, if my differential are these two entities, I do a cocktail.
Right.
Not a cocktail, whatever you call it.
A bag. Yep.
Yeah.
Okay. All right. So Tanner.
What is a tuma for 300?
It is a tuma for 300. This non-salivary organ produces a similar tumor. This non-salivary organ. Yes, Perry gets it with what is pancreas. So what is the tumor? What's it called in the salivary gland? And what's it called in the pancreas?
Ooh, so I know this is a tumor of the acinic cells. What it's called in the pancreas, I actually am completely blanking on the name. Oops, sorry.
Exactly. So strangely enough, it's just a matter of a couple letters, right? So acinic cell carcinoma is the tumor of serous acinar cells of the salivary gland, and acinar carcinoma is the name of the same serous acinar cell tumor in the pancreas. So acinic versus acinar, basically a conglomerate of just serous acinar cells without any structural adipose or ducts but essentially these cells are exactly identical to just the normal serous acinar cells, but forming a mass. These are generally considered low-grade carcinomas, but can have high-grade transformation. Excellent. So Perry gets the next guess.
Sorry, I was muted again. Why don't we do, it is a tumor for 400.
It is a tumor for 400. The pictured tumor was originally named after a tumor in this organ. The pictured tumor was originally named after a tumor in this organ. Yes, so back to Melissa with what is breast? So what tumor is it and what was its original name?
So I think this is the mammary analog secretory carcinoma. I don't remember what it is in breast.
So it's just secretory carcinoma of breast, or sometimes juvenile secretory carcinoma, but essentially we saw this before, right, with ETV6 NTRK3 rearrangement. We saw the microcystic secretory pattern. Sometimes it can be circumscribed, but it was described after its analogy to the same tumor of breast. So originally it was called mammary analog secretory carcinoma, or MASC, but subsequently was kind of discovered to actually be much more common in the salivary glands and outside the breast. So I think now the preferred nomenclature is just secretory carcinoma, eliminating the mammary analog, because we want to distinguish ourselves that we're not, we're not following the breast. Breast is basically a glorified salivary gland, not the other way around. So just kidding. So that's my 2 cents on secretory carcinoma. Anybody else have any comments? Okay, go for it, Melissa.
It is a tumor 500.
Is a tumor for 500. Good, we're at 854. I think we're gonna get through it. When diagnosed in the parotid, this is the most likely site of origin of the pictured tumor. When diagnosed in the parotid, this is the most likely site of origin of the pictured tumor. So yeah, this was the one we saw the answer to. Thanks, Melissa. But yes, it is cutaneous squamous cell. It is skin. So we can not give points for this one, or we can give points to whoever answered it. Yeah, everybody write it in. No, just kidding. So yeah. So
does everybody know? But where in the skin it comes from? Where is it most likely coming from in the skin?
So I think we have the correct answer from a couple of people, including Tim, as scalp, right? So Tim,
Yeah.
Tell us why scalp.
I mean, just in general, cutaneous lesions being represented well in the scalp due to sun exposure. Yeah.
And combined with
surface area.
Right, path of lymphatic drainage, right?
Oh yeah, excuse me.
So I mean, I assume, Peter, is that what you were getting at?
Yes, because if you find a cutaneous met to the parotid, you can actually make more inferences than it's just cutaneous. You can actually sort of you can imply what the location is, which is typically scalp. You're not going to see an arm cutaneous squamous cell metastasized to the parotid lymph node. So it's very, very helpful. One, especially if you have an unknown primary, so you'll have this squamous cell met to the parotid, or two, you'll then typically get this vague history of somebody that's had a prior scalp cancer if they don't actually have one concurrently.
Right. Good point. Right. And so we know that tongue type of cancers are going to drain to your lateral sort of level 2, 3, 4 cervical lymph nodes. We know that your midline tongue cancers can, go bilaterally or contralaterally. And we know that the lymph nodes in the parotid and periparotid region are those that are primarily draining the skin of the head. I would include ear in there as well. We've definitely seen ears going to parotid, scalp going to parotid. And even if the patient doesn't have a history of cutaneous skin cancer, with a keratinizing squamous cell carcinoma like this in the parotid, chances are they probably did and just don't remember, or it, got regressed or something. So very, very, very particularly, these are scalp or ear mets. Excellent. All right. So who got it? Who did we say get
Well,
it?
it was sort of given away. So
Okay.
I mean, I'm happy to give myself full credit. So just for the sake of picking, let's do the 400.
Do it. All right. This immunostain, initially discovered in a non-salivary tumor, is positive in the tumor on the left and negative on the right. So we're looking for an immunostain. I'm not going to start the timer because this is a hard one. This immunostain, initially discovered in a non-salivary tumor, is positive on the left and negative on the right. All right, let's talk through it. Does anybody have any differential diagnosis for the tumor on the left? Oh, somebody got it.
Who is that? I can't tell who what user that is.
Who are you, CCF? CCF doesn't want to talk.
Yeah, well.
All right, so let's talk through it then. Who has a differential diagnosis for the tumor on the left? What kind of cells do we see? I'm circling them. What color are they? Somebody. Are these yellow cells, blue cells, purple cells, pink cells, orange cells? Purple cells. Thanks, Adam. Okay. Generally, is it glassy purple? Is it granular purple?
Oh, Adam, just unmute and speak.
It looks granular purple.
Granular and purple. So what kind of cells are we dealing with here?
I think they're acinar cells.
Yes, thank you. We think these are potentially acinar cells, but the confounding factor, right, is that these acinar cells are not forming a solid sheath. They're forming little microcysts, but you can definitely see acinar cells in the background. So, Adam, what is the tumor on the left?
I would think it's a actinic cell carcinoma.
It is indeed a actinic cell carcinoma. All right, so the similar microcystic pattern on the right, but without the purple granules, but with this very glassy intraluminal secretion, is what type of tumor?
Is this secretory?
Secretory, yes. So we've seen this a few times now, right? So these very, very microcystic, densely secretory, but minus the granules, right? So here's a little bit of history, right? Is that previously secretory carcinoma was thought to be the microcystic variant of a actinic cell. There really is a microcystic variant of a actinic cell, which is what we see on the left, but you still see excellently well-developed zymogen granules in serous acinar cells in this tumor, which you do not see in true secretory carcinomas. Okay, so true secretory carcinomas shouldn't have zymogen-filled cells, should have the ETV6 and TRK3 rearrangement, and should be negative for DOG1, whereas actinic should be positive for DOG1. And so the hint was in initially discovered on or in a non-salivary tumor. So what does DOG1 stand for?
Discovered on GIST.
Discovered on GIST, right? So discovered on GIST is positive and actinic. And if this is ever part of your differential, I don't use DOG generally very frequently, but you can. Comments, questions? This is a tough one.
That was Jasmine, apparently.
What? Dr. Cipriani is saying secretory carcinoma, but if any of you do fellowship at MGH, please say secretory carcinoma because her sec is killing me. Really?
Yes.
Secretory?
Yes, as in secretion.
Yeah. No, as in you just said secretion. You didn't say secretion.
It's just secretory. Just say secretory. If you say secretory, I'm gonna vomit. Adam, if you freaking say secretary, so help me God, you're getting thrown out of the 11th floor window.
Secretary sounds British.
Yeah, it's
Oh,
a British.
How about if we say
It sounds
secretary?
very British.
Can we say
It sounds
secretary?
Or like a dry
Oh
one.
yes, secretary is totally acceptable.
Okay, secretary. Last question. Ready? Immunostain for S100 is diffusely positive in these 3 carcinomas. These, I'm looking for all 3. Immunostain for S100 is positive. Sorry, it's 9:03. I know we've gone over time, but we're so close. These 3 carcinomas. Oh, sec champagne. I like that. It's New Year's Eve. Prosecco, Brut. 3. We're getting so close, but we're gonna stop it. I think the closest here is Tanner. So let me get the next slide though. So the answers I was looking for were secretory or secretory carcinoma, polymorphous or cribriform adenocarcinoma, which we saw, and specifically intraductal carcinoma, which was formerly called low-grade cribriform cystic adenocarcinoma. These are non-invasive, low-grade, as their name suggests, intraductal carcinomas that are always also diffusely and strongly S100 positive. I would say that myoepithelial, pleomorphic adenoma. So one, PA is not a carcinoma, right? So I specifically asked for carcinomas. Myoepithelial carcinoma is another option to be diffusely strongly S100 positive. So I agree with that. However, the strength and the rate of S100 positivity in myoepithelial tumors is not always uniform. So you can have some S100 negative myoepithelial tumors. So I'll accept that answer, but it's not the 100% like these 3. So comments or questions on this one? So if you have a diffusely strongly S100 positive thing on a biopsy, these are the 3 that I would probably focus on. Okay, all right. And so I don't know the final scores, but we'll add it up later. So if you want to just, anybody can do it. Anybody can wager and email me. Is everybody ready for Final Jeopardy?
I got everyone's scores, so whatever
Okay,
they
so just
wagered.
make a bet based on what you think you have or don't have. Even if you haven't won anything, still make a bet. It's cool. Okay. Final Jeopardy. This rare salivary lesion, previously thought to be non-neoplastic, was recently discovered to harbor recurring mutations in the PTEN gene. Therefore, it may better be classified as a neoplasm. Please send me an email. Sorry, I thought I. Okay.
How are we going to have people reveal without changing their answers based on what the person before them said? Maybe on the count
Let
of
me
3.
see if
everyone
I
can
got
vote
any
for-
emails.
Oh, sorry. We were supposed to email, not put it in the chat. Oh, oops.
I'm sorry. If I didn't say it, I'm sorry.
No, I think you did. I think I just jumped the gun a little bit.
Okay. Well, great, because you win. So I got one email. I don't know. And the correct answer is sclerosing polycystic adenosis or sclerosing polycystic adenoma. So this is a pretty rare lesion of various ages and glands, but essentially was thought to be a reactive kind of non-neoplastic process of various kind of nodular hyperplasia in the salivary glands, but was recently discovered to have P10 mutation. So sort of like a phenomenon of something like a nodular fasciitis, right? Where we thought this was a reactive non-neoplastic or hyperplastic lesion, but then a recurring genetic anomaly was discovered, better classifying it. So there are some pictures that I have of this tumor, maybe tumor, in my PowerPoint that's on the M drive. Sorry, I didn't put any in here, but that is the correct answer, but you don't win any.
Have you gotten it?
You didn't wager anything.
Have you gotten it?
No. Have you?
I've never, I mean, I would just say that I had, this, everyone talks about it very matter-of-factly, but either I misdiagnosed them, which is highly likely, or I actually have never gotten one. Because I've never made the diagnosis in my life, even though I'm aware of the entity. Isn't that Justin Bishop's thing? I don't know. But anyway,
I've never diagnosed it.
I'm glad that Pari knows the genetics of it, and she made a big mistake.
By not wagering anything. Yeah, no, I mean, when I see it in the literature, like, I get it. It's like sclerosing adenosis like of breasts, but I don't know. I've never.
Darcy, have you gotten one?
No, I had something I called parotid hamartoma with secondary sclerosing adenosis-like changes, but I didn't do any molecular.
That's awesome. All right.
Cool. Well, thanks everybody. I'll stick around for a bit in case there's.
And thanks for letting us join. Happy New Year.
Oh, thank you
very
guys.
much.
Sorry
Thank
about
you,
the
everyone.
couple of snafus. Happy New Year.
Thank you, Nicole.
Thank you guys for joining. I really appreciate it. See how fun head and neck pathology is?
Let's see.
Tim, I kind of stopped taking score. I totally.
Yeah, I kind of figured as much. If you care, I can just quickly say that, if we ignore the final Jeopardy, which we didn't get wagers on,
right.
Third place was Kyle with 1150. Second place was Perry with, I think, 2000. Yeah, 2000 even. And then winner was Tanner with 20. I gave him half credit on the last one just to snack his ego down a little bit. 2950.
So, all right. So I repeat that. Tanner was how much?
Tanner was 2950.
Perry was 2000.
Yeah, 2000. Kyle was
1150.
1150. Yep.
Nice.
Yep. The winning class was the PGY2 class, then the PGY1 class, then 3, then 4. I counted myself towards 4 because it was starting to look a little bit sad.
So for the PGY winners, you tallied up just the individual.
Yeah, I just added up
tops.
all the year classes together. I'll send you the document I was tracking.
Yeah, please, that'd be great. So if Tanner is the individual winner, you said PGY2 is the group winner?
Yeah, mostly because of Tanner, yeah.
Well, I guess that was why I was thinking about
the second
secondaries. But
well, you got the chat log if you.
Who was the second? Yeah, who was the second PGY winner?
Then it would have been a PGY1.
Okay, mostly because of Perry.
Yeah, pretty much.
Okay. All right, so I have a few prizes.
Mia and Ryan and I think was that it? Yeah, they're also contributors. So.
And Brooke.
Yes, and Brooke as well. That's right. Oh, right at the beginning. Oh shoot! Well, that would have been off by not enough to change the outcome. So I missed that one, but.
Okay. Yeah, just send me the document and I'll give the main prize to Tanner and then figure out. I'll just distribute the rest to other people. Perry, Kyle. Right. Whoever participated in their class win. Okay.
All right, I got to answer a page backlog. So sending. Have fun. All right.
Thanks. Bye.
Bye.